finding technology. The president of computer assisted surgeon, and they would be talking. Vivek Mahajan would also be joining, and we'll be having a discussion on robotics. Is it the future and all those stuff. Dr. Rohit Maheshwari is also a computer navigation trained surgeon from Golden Jubilee. We have international faculties from Hyderabad, the Rohtak, New Delhi, Patna, Calcutta, all would be joining as their flight arrives. So we have 3 live surgeries today. First live surgery would be a cemented total hip replacement, which would be done by me, and the templating which we are doing, it would be the same X-ray which I will be doing it. The Exeter hip course, which you all know, the Exeter hip course is going to start, which I'll brief you again in details. Then coming the Royal College of Surgeons accreditation, the Exeter hip course, 3 live surgeries. First live surgery is by myself, Exeter V40. Then we have Dr. Rajkumar Nathesan sir coming from Ganga Hospital. He'll be doing a Corel Pinnacle debut. And Vijay Kumar, Professor Vijay Kumar, who will be doing a dual mobility Libertus hip replacement tomorrow. We have stalwarts, Mr. Kamal Deep sir from England, Mr. Callum McBride from Manchester, and we would be talking about arthroscopic revolution in the hip as well. Is uncemented implant an issue? How to decide the best options? Dr. Rohit Maheshwari sir will be talking about dual mobility infection, how to prevent, and working algorithm for painful THR. Dr. B.D. Chatterjee sir, Dr. C.S. Yadav sir, Dr. Pankaj Valecha sir, Dr. Rajiv Joshi unfortunately couldn't make it. He has MCI inspection today. Dr. Nathesan sir, Dr. Sivat sir came all the way from Rohtak. Dr. Ratnakar Rao is with us at the moment. Dr. Sahil Sangvi could not make it because he has MCI inspection. My friend, our student, Mr. Vivek Mahajan, Vivek Verma, he would be talking about orthopedic oncology. And Vijay Kumar sir, Dr. Arvind Gupta, periprosthetic fractures. I will be talking a lot on different things. John Mukhopadhyay sir, we met last evening, cement in cement. Direct anterior approach, managing dislocations, Dr. Nishikant Kumar. Dr. Arun Singh will be talking about evolution of THR. He worked with Professor Sir John Chanley, so he would be discussing his ideas. Then research work, how is it important in orthopedics, will be discussed by Dr. Rajiv Anand sir. Dr. Sudeep Kumar about the femoral head size matters. Dr. Sushil Kumar, one of the organizers, and he would be talking about Exeter hip replacement, some Exeter cases exemplified. So after us, today evening, I welcome you all and invite you all for the Starstruck evening that would be at New Patna Club. And fortunately, we have Saregama winner Karmakar ma'am, so coming from Calcutta, and we have Anjali coming from Bombay, who is Indian Idol finalist. Malar Karmakar, Manisha Karmakar, and Anjali Ranjan. So with this, I would like to thank you for coming. So let's talk about the Exeter hip course, what we have planned. So we would ideally like all the delegates to come and occupy the first 3 tables and or the 4 tables. So we have the X-ray viewing box there and templates and X-rays placed. So first of all, Mr. Callum McBride will kick off the show by talking on Exeter philosophy. Then Dr. Pankaj Valecha sir, who would be discussing about how to tips and tricks in cemented THR, what is his ideas, and then we'll start off with templating sessions. Dr. Rohit Maheshwari will be briefing on the templates, and then the camera will be focused, and after that we have cement, so you can mix and understand how does cement work. And the good thing is that I have made a book which is placed on all the 4 tables, and everybody will get the Exeter workshop manual by today 12 or by tomorrow morning maximum. And this Exeter hip book contains all the details, how the things are done in a methodical way, and that would be given to all the delegates as a token, and if you read it, you will definitely benefit it. If I'm not able to supply all the books, it would definitely be posted, or they may collect it from me from my hospital. So with this, without taking much time, I would like to invite Dr. Callum McBride sir to talk about Exeter philosophy. Then I would be calling upon Dr. Pankaj Valecha sir. Thank you. We are on.
Good morning. Hear me. Good morning, everybody. My name is Callum McBride. It's a great honour to be back in Patna. It's about 6 years since I was last here. It's amazing to see how much things have developed. Indian hospitality is something I very much enjoy. I have to diet before I come to India because I can guarantee that I'll go back a lot fatter and happier on my return back to England. So thank you. The hospitality's been wonderful so far. I am getting fatter already. I live and work in Birmingham. I'm a consultant hip surgeon. I just do operations on the hip. I don't know anything about knees or anything else, but I'm a specialist hip surgeon. I trained in Manchester, hence the University of Manchester Association. I have to diet live and work in Birmingham because I can guarantee that I'll go back a lot faster, which is a government happier on my return back to England. So thank you. The hospitality's been wonderful so far. I am getting fatter already. I'm going to kick off really by talking about the history and the design of the Birmingham. I'm a consultant hip surgeon. I think I would say on the hip. I don't know anything about knees or anything else. It's pretty difficult to justify. I'm a specialist hip surgeon. I trained in Manchester, hence the University. I very much enjoy. I have to diet before I come to India because I can guarantee that I'll go back a lot faster, which is I'm happier on my return back to England. So thank you. The hospitality's been wonderful so far. I am getting fatter already. Kick off really talking about received a history. I live and work in Birmingham. I'm a consultant hip surgeon. I just do operations on the hip. I don't know anything about knees or anything else. Pretty difficult to justify. I'm a specialist hip surgeon. I trained in Manchester, hence the University. I very much enjoy. I have to diet before I come to India because I can guarantee that I'll go back a lot faster, which is I'm happier on my return back to England. So thank you. The hospitality's been wonderful so far. I am getting fatter already. Talking about I live and work in Birmingham. I'm a consultant hip surgeon. I just do operations on the hip. I don't know anything about knees or anything else. I'm a specialist hip surgeon. I trained in Manchester, hence I very much enjoy. I have to diet before I come to India because I can guarantee that I'll go back a lot faster, which is I'm happier on my return back to England. So thank you. The hospitality's been wonderful so far. I am getting fatter already. Talking about I live and work in Birmingham. I'm a consultant hip surgeon. I just do operations on the hip. I don't know anything about knees or anything else. I'm a specialist hip surgeon. I trained in Manchester, hence I very much enjoy. I have to diet before I come to India because I can guarantee that I'll go back a lot faster, which is I'm happier on my return back to England. So thank you. The hospitality's been wonderful so far. I am getting fatter already. I live and work in Birmingham. I'm a consultant hip surgeon. I just do operations on the hip. I don't know anything about knees or anything else. I'm a specialist hip surgeon. I trained in Manchester, hence I very much enjoy. I have to diet before I come to India because I can guarantee that I'll go back a lot faster, which is I'm happier on my return back to England. So thank you. The hospitality's been wonderful so far. I am getting fatter already. I live and work in Birmingham. I'm a consultant hip surgeon. I just do operations on the hip. I don't know anything about knees or anything else. I'm a specialist hip surgeon. I trained in Manchester, hence I very much enjoy. I have to diet before I come to India because I can guarantee that I'll go back a lot faster, which is I'm happier on my return back to England. So thank you. The hospitality's been wonderful so far. I am getting fatter already. I live and work in Birmingham. I'm a consultant hip surgeon. I just do operations on the hip. I don't know anything about knees or anything else. I'm a specialist hip surgeon. I trained in Manchester, hence I very much enjoy. I have to diet before I come to India because I can guarantee that I'll go back a lot faster, which is I'm happier on my return back to England. So thank you. The hospitality's been wonderful so far. I am getting fatter already. I live and work in Birmingham. I'm a consultant hip surgeon. I just do operations on the hip. I don't know anything about knees or anything else. I'm a specialist hip surgeon. I trained in Manchester, hence I very much enjoy. I have to diet before I come to India because I can guarantee that I'll go back a lot faster, which is I'm happier on my return back to 15 years, 96% are still working at 15 years. That really is outstanding. But that's found also in Australia. And again, if you look at the Trident, of which there's 55,000 of those put in Australia, at 10 years, 96% are still working also. So it's an extremely successful combination. So, the Exeter is an evolution of a successful initial monoblock to allow different bearing materials and head lengths. The cementation and double taper slip philosophy allows a custom device effectively to use in each patient. It has excellent results both from individual series but also in joint registries, many countries, in many different types of patients. And so it's difficult to argue against using the Exeter, not using the Exeter for all your patients for hip replacement. Thank you very much.
Any questions? Hello. So actually, as reinforced, first of all, thank you, Mr. Callum McBride, for coming to India, appreciating our efforts and be a part of AMC. And thank you for the wonderful talk. Thank you. So basically, why we are focusing on Exeter, you'll come to know in a couple of few lectures. Exeter, when I'll talk, I'll just tell you that Exeter is a wonderful stem because it is personalized, sort of personalized. And you have so many options, right from 33 to 50 offsets and 44, 125, that's the newer things. And they are keep developing newer offsets in process. So this is a boon, actually speaking. And it's, if you know the cementing techniques, it's not a thing to, if you have Exeter, you'll bail out with any surgery. Whether it is a DDH case or anything, periprosthetic fracture. Anyways, two things which I would like to make an announcement, that the stalls, the industry symposium is on. Secondly, all the talks are being loaded to the YouTube, and by the time the speaker ends this talk, it would be live recorded on AMC channel, Anup Master's Course channel on the YouTube. And if you are very happy, you can download the application and you just press the live TV and you will be screened all the talks and everything. And apart from that, we are live on the YouTube as well, and News for India Nation live. All the things are on. So when you're recording all the talks, you can see the last year all the talks are also updated on the AMC course on the YouTube. And this year also it's being done as we talk. So with this, I would like to Mr. Pankaj Valech is already on stage. He's one of my good friends, and I'm very happy that he finally agreed to be a part of AMC. So Mr. Pankaj Valech, all yours.
Thank you, Dr. Ashish. Good morning, friends. That's my disclaimer. I have no conflict of interest with this event or any such activity happening here. Guys, do you know that there are more number of people living today than have ever died? There are more number of people living today than have ever died, which means that we are going to do a lot more totally arthroplasties in the coming times. And that's why this particular program makes a lot of sense today. That brings me to these three fundamental questions, which we say why, how, and what. What do I mean by that? So everybody sitting in this room would know what I'm going to talk about, because this session is about cemented hip arthroplasty. And many of you would also know how it is to be done. But friends, why is the most important question which you should ask? Because till the time you don't know why we are listening to this, why we are talking about cemented hip total hip arthroplasty, it is very difficult for you to execute what we're going to tell you now. So the fuzziest question, which is the why, has to be answered first. So we go inside out. Let me start my talk with the first slide, which is from the Exeter group, because the most common thought which comes to a surgeon's mind is about the morbidity and mortality which may happen on the table or in immediate post-op. So the Exeter group actually conducted a study from 1988 to 2005. They studied over 9,000 primary total hip replacements, and they found that the rate of sudden death in cemented THA is nearly zero with modern cementing techniques and with specialized anesthetic protocol. I'll try to touch upon the relevant points during my talk. The Swedish Hip Register tells us in a study of 1,70,000 patients that they have 94% revision-free survival of 10 years. We also have our Indian Joint Registry now, which is in early years. We already have 25,000 total hips registered with us, although only 20% of the surgeons are contributing to it. The process to streamline it and to bring more patients into the study is going on. In fact, Dr. Jawahar Pachaure, who is the main person behind this, he is going to meet the political leaders to connect this with the Aadhaar card and other such patient identification numbers. We have unsurpassed results in many studies coming from many busy centers and high volume surgeons like Dr. Dan Berry and Craig Delavelli, and they have shown very good results over the period of 20 years. We don't have to go very far. Our own Dr. K.T. Dholakia, it's his case, which I was lucky enough to revise it. This patient stem and cup lasted almost 24 years. At this you can see that the cup has given away because it was a normal poly and there is a bone defect on the top. But when I went in, I could actually do only the cup and the stem was very well fixed there. So improved cementing techniques lead to improved long-term results in total hip arthroplasty. That's very well documented. So now we know why we should talk about cemented total hip, and now it brings me to a point how we should do it. So the technical key points will be divided into two parts, one on the socket side and other on the femoral side. So friends, socket science is no rocket science till the time you know the basics. The preparation of the cemented socket does not require a hemispherical reaming, unlike an uncemented socket. Because in uncemented socket you need a perfect hemispherical socket, which is not required here. You actually ream 3 to 4 millimeter more than the desired cup size to get a good cement mantle there. Every slide I would try to give you a bullet point which is backed by literature, and you will see some good literature listed in the slide. You have to achieve a dry socket. Till the time you don't get a dry socket, you're going to get some blood in the interface of the bone and cement, and which is going to lead to early failure. As you can see here, there's already a radiolucent line, can be seen in all the zones, and the zone 1, which is the weight bearing zone, is the most critical zone. So if you have blood at the time of cementing, you are definitely going to see a radiolucent line, and which means that you may end up with early failure. In Dr. Ranawat's study, they said that if there is no zone 1 radiolucency in the immediate post-op X-ray, then your revision rate is only 0.69%. Just to simplify it, if you have an early radiolucency, then it means you have inadequate control of bleeding, you did not get a dry cancellous bone. The cement pressure is very, very critical. It means you did not achieve that as well. And we all know that cement leaks from here and there when we are cementing the socket. We'll talk about the tips to prevent it, and inadequate coverage of the cup. This is about the anesthesia protocol. My anesthesia team gives me hypotensive anesthesia wherever indicated. But friends, hypotensive anesthesia is not for every patient. You have to choose your patients very, very selectively. We do not give hypotensive anesthesia to patients who have any cardiac, renal or cerebrovascular comorbidity. We can also decrease the patient's blood pressure by giving high dose of epidural or spinal anesthesia. And if we are using hypotensive anesthesia, then the duration must not be more than 1 hour, because then it starts affecting the renal function and other critical functions. There are multiple other things. I've just tried to put some relevant things here. It's a big science. The anesthesia team or your anesthesia team can take care of it. Now comes our part about the technique. Now pulsatile lavage is one thing which has shown in all studies to give us good outcome of cemented total hip arthroplasty. Because it's not only the volume of the saline or the fluid which you use. It's not that you pick up a lot of saline in a bowl and just pour it there. You have to do the pulsatile lavage to take away the dry bone and the fat and the bone marrow which is sitting there. Then you should use multiple fixation holes, especially in the dome area, and one each in the ischial and pubic area. That gives you a good macro lock also when your cement is setting. And that's how you can do it. You can actually use a long drill bit or a Steinman pin to do that. Cement pressurization should be done with a cement bulb, or you can use it a silicone pressurizers also. They are available with us like this. They are available very freely. If you are reaming if you're intending to do a 48 cup, then you should use a silicone pressurizer of 52, so that it is relatively bigger in size, does not allow the cement to come out when you're pressurizing. Once you get when the cement doesn't get a place to come out, it goes into the bone. There's no other place. and to increase the pressurization in the zone 1, which is little difficult to do because you have to either pressurize with your thumb. There is a tip. You can actually take a small reamer and create a trough in the dome area. That takes away the sclerotic bone from that area, takes care of your subchondral cysts, and also creates a contained defect there, which restricts and traps the cement in the dome area. So when you're putting in your cement, at your cup, at that time the cement stays there. So you have to completely bury your cup wherever you can, but if you have to decrease your abduction angle, if you want to close the cup, even then the 80% of the cup has to be contained in the socket. If it is more than that, then it affects the longevity of the cup. I'm going to show you a simple technique, doable technique by anyone to prevent the cement leak. As you go in, you can see this is the cup holder and this is the socket, and these green lines are cement. So when you're putting in your cup, you bring a T-handle or a pressurizer, which is called the inferior pressurizer. So you introduce your cup inferiorly and put a pressure with a T-handle inferiorly. Then you move your cup holder to a desired position where you want your cup to sit, and also correct the antiversion to your desired level. Once you have done that, your cup sits in, your cement doesn't leak from the TAL area, which is the area where we don't have any bone, and then you come with a central pressurizer with a ball head to hold that position. That contains your cement very nicely. You have created a trough in the dome area which is containing the cement. Inferiorly you have locked, the cement will go medially and everywhere, the dry cancellous bone wherever is available. That brings me to the technical key points on the femoral side. The pulsatile lavage, as I told you, is one thing you must have on your table when you're doing a cemented total hip. You have to take care of all the bone marrow and fat sitting there. You have to achieve actually dry cancellous bone and not the cortical bone. Do not expose the cortical bone while you are preparing the canal. And many studies have shown that manual lavage carries a significant higher risk of landing up with a fat and bone marrow intravasation as compared to pulsatile lavage. Pressurization of cement is an issue here as well. So as Mr. Callum McBride was touching upon this, that cement pressurization is a critical thing, and we all must understand the basic techniques of doing it. So it's not only the magnitude, it's also the duration of pressurization and what kind of cement you're using. The cement viscosity has to be, you have to choose your cement well. And also the stem design. We have heard in detail about the axiatus stem, the tapered stem, which creates good intramedullary pressure to get a very good interlock. You can use, there are multiple terminologies going around, generation 1, generation 2, 3, and we now have 4 also as with vacuum mixing coming in. But just to keep it simple, usable tips, you can occlude the distal cement in the femur by using a plastic cement restrictor or even a bone plug. You have this simple set available wherein you can actually, with this first device, you can take a bone plug out of the femoral neck once you have taken the neck osteotomy, and then take this out with a plunger, and then you can actually pack it in with these different sized impactors according to the stem which you have used. They are matched to the stem size you're using, and it goes and sits there very, very nicely. When we say the viscosity of the cement, then actually you have to use a high viscosity cement, and it does not mean that you can't inject that cement. A high viscosity cement by definition is less of waiting time and more of working time. Most of us are using simplex cement when we are cementing our femur, which is actually intermediate viscosity stem, which gives you good waiting time as well as working time. So if the viscosity is higher, actually it displaces the bone marrow, and it gives you, the cement enters into the bone marrow, into the trabeculae, and gives you a very good interdigitation. We have talked about the distal occlusion, about the cementing technique, and also the proximal pressurization, which is trickier than the other two things. We have silicone pressurizers available very freely, which are very easy to cut. You can actually load them on the gun, as I've done here, and after that you take it up, you take it higher. It goes higher, as you can see in the fourth picture. It is sitting very close to the cement gun, and then you start the retrograde filling. Once you have done the retrograde filling, then you cut it from there like this, and then you start putting pressure in the proximal part. This cement pressurizer will give you block on the front. Distally you have occluded your canal, so there's only one way the cement can go, that is inside. You have to generate a lot of pressure here when you're doing it. There's a line which goes here that you have to make your femur sweat. You have to make your femur sweat. You can see actually the fluid coming out of the posterior surface of the neck when you're doing it. And then comes our tapered stem, which generates even further pressure when you're going in. And this gives you a very good whiteout cementing, and very good longevity in the long run. So my commandments, my friends, are very simple. You have to take a good incision. These are general commandments. You do not fight against the soft tissues. You let the soft tissues fall into their place and do your job nicely. Hypotensive anesthesia wherever indicated. Pulsatile lavage has to be there in every cemented total hip to achieve a clean and dry bone. On the socket side, ream 3 to 4 millimeter more than the usual size which you are going to use. Multiple fixation holes in the dome area and in the ischium and pubis. You create a trough with a small sized reamer to trap your cement in the dome. Use a silicone cement pressurizer for the proximal, for the seal of the cement when you are pressurizing, and try to completely bury your cup, or at least 80% should be inside, and prevent cement leak. On the stem side, use a good stem with a track record. We are talking about Exeter. We have heard a lot about it. It's a wonderful stem with a very good long-term results. You achieve solid distal occlusion. You know your cement and know the cement timings in your theater. How much time do you need to cement in your theater, in your setup? Don't toggle the stem when you're inserting it, because it is going to displace your mantle and it can lead to early loosening. And good sustained proximal pressurization and maintaining that pressurization when you're actually putting in your stem. These are the few basic things you must do when you're doing a THA, cemented THA. And I'll end my talk by saying of a great Greek philosopher, Socrates. He says, I cannot teach anybody anything. I can only change the way you think. Thank you very much.
So I'm very thankful to Dr. Pankaj Valecha sir, and it was a wonderful talk. Now we would shift to practical sessions. So I just counted the head counts, and we are roughly 58 people on board right now. Yes, sir.
Good morning, everyone. I am very grateful to the Ashish and his team to invite me. And in the beginning of the session, I just want to make 2-3 comments which are very general. And one is that Exeter is not a panacea. One must understand very clearly. Whole day we will talk Exeter cement, Exeter cement. There are many other things better than Exeter also. About 20 years back, I visited Exeter University. The name of the stem is designed on the name of the university. There is Exeter University in the, I think, west of London or south of London. There is a university. It is a very good system. It is an excellent cemented system out of all the available triple or this. But problem with our system is that they don't give the instrumentation which is actually designed by the Exeter hip system. Like Dr. Valecha was talking that how to pressurize the cement in acetabulum. They give a water pressurizer, but we don't find here in our set that you can pressurize the cement with that. They give a yellow U to metal as well as the silicon just to pressurize the cement. If you add anything, that will add to the cost of the surgery. The major defect with the Exeter is that they do not provide the surgeon what all instrumentation are designed to be given, so that we need not to add to further add to the some instruments, and that will add to the cost. Second thing which I have realized over my 30-year experience is I have around 18-year follow-up of Exeter cemented hip, is that this flanged, the centralizer, is one of the best thing available with Exeter. Your center is only not that your center goes, the cement, your stem goes in the center. The most important part is that when you put the cement mantle around the stem is equal all through 3 mm. Thirdly, I just want to put a point. Dr. Valecha said that you ream the acetabulum 3 to 4 millimeter more. you need not to ream, because this 3 millimeter already integrated in your reamer. But unfortunate part with us is that we ream the same reamer, use the same reamer for cemented, same reamer for uncemented. For cemented stem, they are incorporated in the reamer of the acetabulum that it will be 3 to 4 millimeter already. So you need not to change your reamer. But in uncemented, you have to ream the same as you are putting up, because there is a little higher diameter on the implant size. That is few points which I want to make to the house, that it is designed on the name of a university that is known as Exeter University. Thank you very much.
Thank you, sir. Actually, Dr. Sivaj sir is rightly said. Actually, Exeter is not a panacea. You have options. If you have a look at this room, you won't see any company, industry, banners and all. That's because we get toggled if we see something which is being focused. The most important thing which I think we need to understand is the technique of cementing, because that makes a difference no matter what you do. So don't be dogmatic. So normally what happens when we go to the meetings, when we talk amongst ourselves, we talk, okay, which knee did you do? So somebody says, I did a Zimmer knee. Somebody says a debut knee. Somebody says a striker knee. But we never talk about single radii and multiple radii knee for that matter. In the same way, the stems are of 3 types in cemented stems. Now one is bi-flange designed, that was developed by Muller, which has got a hard surface, and many of the companies make that stem, which I remember is Ormed is one of the companies, which is rough in brown in coating. Second is the C shape, which was developed by Charnley and the Exeter group. So these 3 main things. So what is important to understand is how the cemented stems have failed. So the broad shoulder cemented Exeter stem, the longest track record is 33.3 years till date. And what the good thing about the thing is that at the local level, they have a good instrumentation. So which we don't get in other companies. I won't quote the name of the companies, but when you open the stem, you have options. So if I take it from the very beginning, you have 33 offset, which is the smallest available, then 35.5, then 37.7, 37.5, which is what we use in India. But when we work in the West, the basic offset becomes 44. And if you want to increase, it becomes 50 and 56. Apart from that, 44 at 012 and 37.501. And the most important thing is that you have 44.125 offset. So the most important thing which I would like to put it in everybody's head is understand the instrumentation and what all options you have. Because the long stem also is quite, you get the long stem. Regarding the cemented tip, we put a centralizer. That is a very good thing, and if you read the Exeter textbook, which is available on the net, the stem actually sinks, it subsides, it goes up, and that is by the virtue of the cement centralizer, which we don't get in other companies. They don't provide. And cement restrictor, if you don't ask for, you don't get it. So that is also very important. I'll show you some cases where we had to revise and the cement was up till mid shaft. So you have to do an ETO and get the cement out if it is infected. So what the moral of my couple of words is that we should not be dogmatic. Exeter is a good stem, but it has its own pros, cons. Understand templates, understand cementing techniques, understand the philosophy, how it fails, and decide what you have in your armamentarium and what the company gives you at the best. Any questions up till now?
Sorry, I am disturbing you again. That what yellow shield they give with the company itself is because you had to keep it pressed about 7 minutes because cement expand 25% of what you have put in. If you will not put, that will push your stem up properly. And there is no doubt about the designing, about the cementing. It is excellent thing. There is no doubt about the stem itself or the head itself. I have no doubt this is one of the best stem. But we had to emphasize on the issue that we should have a correct and all available instrumentation at our table while we are doing that. Thank you very much.
So thank you, sir. Now let's plan. So the X-rays I have just put in today for practice is the same X-ray V40 which I would be doing. So let's see what I am able to put finally at about 3 p.m. So for this session, what I have done is we have 3 to 4 tables and the faculties would be on each table. But first of all, Dr. Rohit Maheshwari sir from Golden National Jubilee Hospital would be demonstrating how do you template. We have loads of X-rays. We would be practicing 2 templates. I mean, everybody should practice one simple and one complicated and take it from there. So we have to understand how do you make mark, how do you draw a line, and then calculate it is 100% film, true size ratio 1:1, and the actual templates available. So at this time, I would like you all to gather in about 4 tables, and individually you have templates in X-rays. We'll supply them more. You have light source and practice, and I'll take a note which table gives me the sizes, and then we'll see which size I put in the afternoon. And planning to fail is failing to plan. So other way around. So we should plan each and every case. Unfortunately, in India, the digital templating system has not come up. It's a wee bit on the higher side, cost effective. It's not cost effective, but it's very good. But nevertheless, we have templates, the company people we should ask for. You can get it Xeroxed actually and use it. And I'll hand over the mic to my senior colleague, Dr. Rohit Maheshwari sir, who has come all the way from Glasgow. Thank you. May I request to come forward?
Thank you, Ashish, and it's a great pleasure to be here. I've got Dr. Samir with me, and we worked together a couple of years back as well. As Dr. Ashish said, why you want to plan now rather than in the theater. Okay, so that's important. The second thing I want to say is basically I've not done these templatings for last 15-20 years because we've been used to doing packs. We are used to doing OrthoView, which is basically a digital templating system, but nevertheless I will try my best to show some basic concepts regarding templating. To begin with, first of all, you need to make sure that you got all the identification for the patient, where you're templating for the right patient or not. That is very important. Whether you got adequate X-rays or not, and how would you judge whether the X-rays are adequate or not is looking at the pelvis, looking at the femur, and see whether you got any magnification marker on the X-ray itself. Unfortunately, on this X-ray we don't have a magnification marker, so we don't know how much magnification factor we should be considering while judging with our implants. Looking at the X-ray itself, you look at